Okay, well, officially good afternoon, everyone. Thank you so much for joining us for ACMHAI's webinar on the Illinois Children's Behavioral Health Transformation Initiative. And pleased to have Dr. Weiner here to join us and give us an update. A little intro before we get started. Dana Weiner is a Chapin Hall Senior Policy Fellow with over 20 years of experience providing technical assistance, program evaluation, and data analytics support to child serving systems across the country. She's currently serving in the office of Illinois Governor J.B. Pritzker as the Chief Officer for Children's Behavioral Health Transformation. In this role, she oversees the implementation of recommendations to adjust capacity and streamline access to mental health services for youth. Dr. Weiner holds a bachelor's degree from Cornell University and a PhD in clinical psychology from Northwestern University. So thank you so much for being here and providing an update to all of our members. We appreciate it.
My pleasure. Thanks for inviting me. And I see we're kind of a nice small group, so I'm hoping that I can speak kind of informally with slides and then we can have some conversation about where things are at. So I'm going to share my screen and get this show going. Okay, so Jody and I were just reflecting. We think it's been like a year since I spoke with you all, and I don't know if all of you were in that conversation, but I think at least some of you were. So I'll try not to repeat anything that I said then and bring you up to speed on what we've been doing and what we've accomplished, which is kind of a lot. And then we can talk about implications for you all in the community and network work that you're doing. So just as a reminder, this initiative was established in 2022, coming out of the pandemic. The governor's office and many other people were concerned about increasing rates of young people with mental health problems, a diminished workforce, and a lot of families having trouble getting the services that they needed for young people with mental health challenges. And so initially the question was, what are the gaps in our system? Why is it taking kids so long, particularly those kids who are stuck in inpatient hospitalization, but why is it taking everyone so long to get what they need? And as a result of that request, we produced a blueprint, which was released in early 2023. And because we have a governor who's extremely committed to this issue and a General Assembly that's also supportive of this work, we ended up with an executive order signed by the governor basically saying that this blueprint would be the law, that we would implement all of it, and installing me in this position to oversee the implementation, which is thrilling and slightly terrifying because it means I'm working across 6 state agencies that typically have not collaborated seamlessly to try to get big changes made in our system. And I'll remind you what those changes are and tell you what our progress is on implementing them. So these are the 6 agencies: DCFS, the Child Welfare Agency; DHS, which has multiple divisions that we work with, including developmental disabilities and mental health; DJJ, which has kids receiving services in aftercare; IDPH, which oversees inpatient hospitalization, but is also a key partner in our community strengthening strategy; ISB, the Illinois State Board of Ed, that has a very decentralized system of school-based supports across the state; and then HFS, the state Medicaid agency. And each of these agencies has a role to play in providing behavioral health services to kids. But prior to our initiating this work, they really didn't have an easy way to work together on getting services to families. So we set about doing what's in the blueprint, and that basically boils down to these 12 strategies. You've seen this slide before. This is just a reminder. There's 4 strategies designed to streamline and centralize service access, and 3 of those are pieces of technology. And I'm going to give you updates. We've made good progress on number 1 and number 3, and progress on number 4 is coming. Then we've got 4 more strategies designed to make sure we have enough of what we need. And I'll talk a little bit about at least one of the types of services that we're adding. But we are getting better at using data to see what's needed and pivot where we need to pivot. And then in the right-hand column, you see 4 strategies designed to help us get upstream of problems. And we've made good progress on some of these, particularly number 9 and number 12, which I'll talk about. So, but this is just to remind you, when the blueprint was signed into law, these are the 12 things, and this was our job, was make these things happen. Some of them are harder than others. So we stood up implementation teams focused on the different issues, a technology team, a program development team, a school team, a community team, and then data and fiscal work groups. And each one was co-chaired by one of the Chapin Hall analysts on our team and an agency person. And those agency people, basically, we distributed responsibility for the 12 recommendations that you saw 2 slides ago across the 6 agencies. So DHS, for example, has primary responsibility for implementing 4 of those strategies in partnership with us. DCFS has 3, ISB just has 1. And so this is the way we kind of distributed the responsibility across the agencies, but also then have leadership from the agencies with the darkest green square. They work with us on driving progress in each of those areas. And this is how it's going. So this is how we kind of track our progress. And I don't remember if I showed you a graphic like this before, but we certainly, oh, and actually yes, this is the most recent one. So the length of the colored bars here is how long we projected it would take to accomplish each thing. So as you can see, the purple bar for number 9 is universal screening in schools. We thought that would take 5 years to accomplish. And as you'll hear in a few minutes, we've taken a very slow, methodical approach to implementing this. And indeed, it will take the full 5 years to do, but we are on track with it. Some of these things, like number 1 and number 3, we have finished. So those are you can see the dotted line is, well, it's where we were a month ago. I need to pull a new progress tracker, but that shows that those strategies we've completed our work on them. And now we're working to implement and integrate across different strategies. So I'll just highlight some of the biggest accomplishments, and we can talk more about these if you have thoughts or questions. The first is the public release of Beacon. So Beacon is the centralized care portal. You might remember that early on in this work, we stood up a very rudimentary version of a care portal. And I think I told all of you, you could enter cases into it if you knew of a kid in your community who was stuck in the hospital and needed a residential treatment bed. Now Beacon is available to everyone across the state, all families, anybody who wants to use it. And I can tell you that anywhere between 100 and 500 people access Beacon every day. The majority of them are looking for information about behavioral health services. So, and it's really only a handful, like between 2 and 6 people every day actually start a case for assistance by the state team. And I'll explain how that works. But this tool was released in January of 2024. And so we've been using it for just about 6 months for the public, a little bit longer for school personnel and other key partners. So, and it accumulates data in a set of dashboards so that we can see exactly how many cases are served, how long they wait, how satisfied they are, what types of problems they have, all kinds of information that we didn't have before. The second tool that we released so Beacon is very visible to everyone. This capacity reporting tool is not visible to all but a few people at the state, but what it does is very important. Prior to this work, each of those state agencies contract separately for residential treatment beds. And these residential treatment beds were an important piece of the puzzle because kids were stuck in the hospital beyond medical necessity because they could not get into a residential treatment bed. Or worse, their parents were voluntarily relinquishing parental rights to the state to take custody of kids in the hope that that would get them a residential bed more quickly. It doesn't get them a residential bed more quickly. It opens them up to a whole other array of problematic potential outcomes. And we shouldn't be sending kids into state custody in the absence of abuse or neglect. This capacity reporting tool, back to my accomplishment here, the capacity reporting tool allows us to see how many residential beds are available because any provider across the state who delivers residential treatment must every morning go in and enter their current census, how many beds they have available, how understaffed they are. It takes them under 2 minutes to do this, and they are about 97% compliant with this requirement. But it took a lot of work to get it to happen. We had to pass a law. We had to amend all of their contracts. We had to talk a lot with providers and with tech developers to figure out what kind of solution would work for them. But I'm happy to say that now we have a data source that tells us in real time where the empty residential beds are so that we can more quickly get kids out of the hospital and where they need to go. The third thing I'll mention is that we also have launched a pilot program to provide in-home behavioral health aids to the families of kids with autism spectrum disorders. The idea here is that some of these kids are eligible for a one-on-one aid in the school setting, in the classroom, and they need that one-on-one attention to stay still and attentive, to stay regulated. But then they come home from school and their parents need that same level of attention on those kids and don't have it. And so if there are other kids in the home, these kids are at risk also of ending up in the hospital and then not being able to come home because their parents say, I can't provide adequate supervision and attention for this young person. So this program that we saw was successful in Minnesota and Alaska and other places. We decided, well, let's try this in Illinois. And we applied for a pilot exemption. And we partnered with 2 providers, Trinity and Spring Health. And they are in the process of hiring and training these in-home behavioral health aides that will be available to these families. And the way to access that service is to put the case into Beacon and indicate that that is what is being sought. Or you can talk to me about it or my colleague Megan Jorgensen. The fourth thing I want to highlight is that we have partnered with the Illinois Children's Healthcare Foundation to provide 7 planning grants to family-run organizations. You will probably encounter some of these organizations. We hope that as we build and rebuild community networks, that family-run organizations will play a key role in anchoring and supporting community networks. But we didn't have robust family-run organizations, and now we have 7 that are receiving this technical assistance for a year and a half. They're also getting ARPA funds from HFS. And so this is part of our community network strategy that I'll talk about a little more. The fifth thing I want to highlight for you is that ISB, as I said, we're doing this slow, methodical process to get to universal behavioral health screening in schools. And what happened in the last year is that ISB launched a readiness assessment of all the school districts based on what we had learned in the previous year about the key elements for successful screening program. So then we were able to publish a report that came out April 1st. I can put the link to it in the chat if you want to see it. And that report outlines a phased approach to implementing school screening based on actual data on readiness. And then the last thing I'll mention is, since I already told you we were trying to prevent kids from unnecessarily coming into state custody, that in the first 450 cases that we staffed using our new collaborative process and our new tools, we resolved 356 of them. And among those resolved cases, 187 of them had had a hotline call to DCFS to try to relinquish parental rights to get a residential treatment bed. And we were able to get them a bed without involving the state, without involving DCFS. So that was a big win and kind of a green light to say that these strategies that we're testing are working and that we should invest in them. So I'm going to talk a little bit more about 2 of these recommendations that I think are most closely aligned with your work. One is recommendation 12. So recommendation 12 was about rebuilding community networks, because as you probably know, once upon a time, there were LANs, local area networks, and the state invested in those, and DCFS played a lead role along with other agencies in standing them up and participating in them. But they were kind of divested from over the last 15 years. And while there are still some lands, I visited land 53 and land 40, but a lot of lands fell off. And now what we have is a patchwork of different types of networks, including 708 boards, including system of care grants, including what we call organic networks that maybe were started by a hospital or a church or something to pull everyone together. So what we decided we would do, because when I published the blueprint and people saw recommendation 12 that said rebuild community networks, I think everybody worried, like, oh no, what about the network I'm working on? Are we going to get rid of this and do something else? My rule is I never get rid of anything that is working for people. And in my view, the existing community networks are working. We just need to support them with funding, with infrastructure, with technical assistance, with collaborative opportunities. So what we did was we took a step back and we said, well, first of all, what's a community network? Because a lot of people in our state bureaucracy could not wrap their head around what we meant when we said we wanted to invest in community networks. So we had to come up with a definition that everyone could understand. And this is what we came up with: an ecosystem of diverse stakeholders coupled with braided supports that can help prevent and respond to crises by connecting families with what they say they need to thrive. So hopefully this definition resonates with you. We talked to a lot of stakeholders about it, but we're always happy to make tweaks. I mentioned that when we started this work, we wanted to understand where were community networks currently. And you might remember this. I think Regina Kreider might have presented, excuse me, presented similar information when we talked last year. This is a map of where we know all the networks are, in every county but one has at least one network. And you can see where the 708 boards are represented in the solid green shaded areas. But we have lots of other types of networks. And so we mapped them all because we said we're not getting rid of any of these. We just want to invite everyone to be part of this effort. And what this effort is going to look like when I say we want to support and fortify community networks is it's going to look something like this. We're going to have hubs in each of the IDP, in Illinois Department of Public Health regions. And we might have, you can see like in region 1, there's a 708 board network, there's a land network, there are different kinds of networks in that, and they might differ by region. But in each region, we want to have a network anchor. And I can tell you that IDPH is about to put out a NOFO to provide some funding for the entities that will be the network anchors. And the network anchors might convene meetings or training opportunities. They might have like a learning collaborative type event for all of the networks in that region. They're going to work in conjunction with the family-run organizations. But so I just wanted you to see, like, this is kind of, it took us a while to figure out, well, if we're going to have all these different kinds of networks, what kind of infrastructure will they need? And we've talked to a lot of people in networks who've kind of informed this strategy, but nothing's set in stone, and we welcome your input too. Okay, the other thing I wanted to drill down to, but Jody, like I said, we can be informal. If people, I imagine you might have thoughts or questions already. So if anybody does, you can interrupt me, or we can pause right now, or I can, because the next thing I was going to say was about recommendation 9 and the school screening work. So should I pause here?
Does anyone have any questions at all?
Uh,
Or
my name is Marita Landreth. I'm the director for the Behavioral Health Coordination Department for the County of McLean, and we have an SOC grant. And so yeah, this super aligns with all of that kind of stuff. So we'll probably be reaching out to talk more for sure.
Great, great.
Very
And
excited.
yeah, keep an eye out for this NOFO that's coming
Yeah.
from IDPH, because, you know, when we talk to people, it was this really, what's happening now with community networks is such a kind of grassroots, like bottom up approach, which we really want to support, but we also want to convey to the state that, like, there needs to be support for this, because we can't expect
Yes.
every community to be able to just do, even for the
No.
meetings, even to like bring people together and like give them like juice and donuts or whatever. We need
Yeah.
to provide support to, and also for the outreach and dissemination and engagement that has to happen. So happy to hear that you think it's aligned, and let's keep in touch. You know, feel free to reach out to me. Okay, anything else? Otherwise, I'll keep going. I'm sure. I mean, I still have a lot more to tell you, actually. Okay, so recommendation 9 is a universal mental health screening in schools. So, as you know, many of you were, when you went to school, you were screened for vision and hearing problems. I know I was. The idea being that if you're having trouble hearing or seeing, you can't learn effectively in school. And I would argue that we know enough to know that kids who are beset by mental health problems, have anxiety, depression, trauma, or other types of problems, are also having trouble learning in school. Plus, we don't know, we can't help these kids because we don't know necessarily, particularly the kids who have what we call internalizing problems. We don't always know about them. So that's the philosophy behind implementing universal behavioral health screening in schools. When I first started saying this, a lot of people said, well, that's never going to work. Nobody's going to do that. And the first thing we did in year one was to do a landscape scan because we realized that the Illinois State Board of Ed did not know what school districts were doing for screening. And what we learned was something very important, which is that a third of school districts are already doing universal screening. So much for the people who are like, this is not possible, you can't do it, because you can do it. A third of districts are doing it, but it does require certain foundational things. So in the next year, what we did was, because we did a listening tour and a survey to find out if districts were doing it, what was making it successful. We took all that stuff that we learned, and then we asked every district, do you have these things in place? And it was like 5 categories of things. Do you have policies? Do you have resources in a team? Do you have the necessary tools and technology? Is the culture conducive? Because we know that if the culture is like stigmatizing mental health problems, and you start asking kids and trying to surface those, you might do more harm than good. You really have to tackle all these 5 dimensions that we learned from Schools Matter. So that's what we did in the last year. And then the report that came out on April 1st talked about the level of readiness across Illinois school districts. So you've got the districts that are already doing it. You've got another group of districts that aren't doing universal screening, but they do have a high level of what we would call now readiness. And so that will be phase 1 and phase 2. And then phase 3 implementers will be those school districts that aren't there yet, but we're going to try to get them there. And the way we're going to get them there is, number 1, ISB must deliver policy guidance by September of 2026. And number 2, HFS, the Medicaid agency, is procuring a big technological tool for resource referral that is, in my dreams, is going to be like the open table of behavioral health, where you can use it on your phone to make an appointment for someone. And that tool will include screening tools also for schools to use. So this will be at no cost to those districts that don't have the resources. That will be available in 2027. And based on all of this, we just passed a bill, now it's a law, or it will be when the governor signs it, in the General Assembly, that says that by 27-28, by that school year, all of the school districts will be required to do screening. But they'll be given a tool, they'll be given policy guidance, they'll be given the technology, so it won't be as heavy a lift. We'll be able to focus on kind of the culture and other issues that that are needed. And this, by the way, is that Senate Bill 1560 that passed in the General Assembly a week and a half ago. And it has provision number 4, which is what I was just talking about, that kids grades 3 through 12 will have to be offered screening. Kids can always opt out. Parents can opt out on their kids' behalf if they don't want their kids screened, but districts must offer it to every student. The other 2 provisions in our bill this year had to do with making sure everyone's aware of Beacon, because it's not easy, but the easier part of making these big systems changes is implementing the new tool, building the technology. The harder part is getting everyone to change the way they do their work, because people are used to doing their work with the old tools or lack of tools. And if we want them to adopt new things, we really have to get everybody to do things differently, which is difficult. And it requires, I've learned, some combination of policy change, like you put it in a law, but people still really don't do it. They need to be supported, they need to be educated, they need to be communicated with, and sometimes they need to be incentivized to do the new things. But that's a whole conversation about change management. Anyway, because I'm talking to a community network audience, just want to illustrate that the student screening is that littlest pink circle. Everything happens within multiple ecologies. So you've got the parents that now have the Beacon tool, you've got the school community, and we have supports that hopefully will survive federal funding cuts, things like Project Reach and SEL hubs. But we also have this resource referral tool that's being developed by HFS. Then you've got the community networks in that second to largest band, and then you've got the larger system of our state. Okay, so I'm going to shift gears and talk about Beacon to make sure you all know how to use it and what it's for. Any questions before I do that?
I have a question.
Yeah.
This is great work, Dana. I know you have really accomplished a lot. I had a question with the universal screening, which again is awesome to hear that it's advancing beyond those that are already have those instruments and using them in the school setting. My question is, what are you doing in terms of looking at capacity issues? Are you looking at additional resources for school-based services or community-based services? Because I think one of the things is once we start identifying kids, we also want to make sure that there's services to support them. And I know like one of our high schools here just locally just shut down. They had school-based services. It's our biggest actually school district, and just kind of severed the contract with our provider to provide school-based services. So just, is that something on the radar as well that you're looking at?
Yeah, the capacity, I have said all along that like we can't work on these things sequentially, like because anytime we do one thing, we create tension in another part of our system if we haven't kept pace. So if we don't increase capacity while we're streamlining access, then we have a lot of people who have access, but then they're waiting for stuff. They can see what they should be eligible for, but they can't get it. So I absolutely hear you. The argument I often get is, well, we don't want to identify these kids with problems because what if we can't help them? And this is a difficult tension because in my observation, and this might, I don't know how people feel about this, but in my observation, if we keep not identifying the people because we don't want to know about anyone that we can't serve, we don't ever experience that pressure that causes people to say, oh, we have to allocate money to this. We have to train more people to do this. So I'm kind of on the side of that argument that says these kids are struggling anyway. They end up in the hospital because nobody ever asked them earlier. My argument is we have to surface the level of need that lets us then advocate for additional services. But I don't want you to think that we're not doing anything. We are launching new programs, the one I mentioned about in-home aids, but also a transitional setting for kids with developmental disabilities who are aging into adulthood. But I know that we need a lot more community behavioral health resources, and whether that happens in the context of school-based clinics or whether it happens through partnerships with community mental health and the new CCBHCs that have been launched through HFS. I think the latter is more likely in a lot of places, that partnering with the community-based either mental health centers or these comprehensive behavioral health centers is maybe a more likely scenario. But I'm also hoping that the community networks can play a role in fostering those linkages. Unfortunately, I don't have the solution to something like the specific example you're giving, where like there's been either a shattered partnership or a divestment from a provider. I think it's just important that we surface the need so that we can keep targeting resources to where the need is. But I think everybody at the state level really wants these strategies to be successful. And so I've had a lot of success advocating for resources, targeted resources to be devoted to the things we keep uncovering. Like with each new strategy, we find out about a group of people that, oh, we don't have anything for these kids who are turning 17, 18 with developmental disabilities. And now we have some willingness to like fund a pilot program and demonstrate that that's needed. So Deborah, I know that's not like the most satisfying answer, but we're trying to tackle all the things at once.
No, that was a great answer. And yeah, I realized that probably as soon as you're addressing one issue, 5 others kind of rise up. And again, our situation with the school is kind of an individual thing there, and something that we need to work out in terms of the community and how we'll address that need. But just was really interested in just your thoughts about what you might be looking at in terms of capacity if that evolves out of that. But certainly a proponent of the universal screening for identifying these youth.
Okay, great. Other questions, or I'm going to tell you about Beacon. Okay, so you might recall, you probably remember this picture. It's like my favorite graphic. We made Beacon because families told us that if their kid needed residential treatment, it was like navigating a dark, unmarked forest. They were scared. They didn't understand what the next steps were. And what they got depended on which door they came in. And there are 5 state doors that could get you into a residential treatment bed. You could get it through the developmental disabilities waiver at DHS, through the family support program at HFS, through the school district, if you have it in your IEP, through DCFS or DJJ, although those pathways are not the desirable pathways. So what we tried to do was build some technology that would make this less scary and confusing for families, and also let us all see more clearly what the steps were along the process. So I'm happy to say that now it looks more like this, where no matter which pathway you come in, you're met with information. There's a little trail map kiosk, a little park ranger to help you. And so what Beacon has done is 4 key things. One, it put all the information about state-funded services in one place. So people don't have to search 6 state agencies' websites. It all lives in the Beacon portal. And it matches, like if you put in characteristics of a child or what they need, it tells you which things your child would be eligible for. And that's based on Appendix E of the blueprint. The other thing it does that was not possible before, it lets you talk to a human. If you want someone to call you, you indicate, I would like more help. And the next day, within 24 hours, someone from the team at DMH calls this family back and says, what can I help you get linked with? And if what they need is residential, they get connected to someone called a clinical specialist. But if all they need is like how to access community mental health services, the resource coordinators handle those requests. And like I said, maybe a few hundred people come to Beacon every day, only like 5 say, please call me, I need help from a human, but those 5 all get calls back. The other thing that this does, 2 more things that it does, Beacon lets families create an account where then they can check back to see the status of their request, but they can also upload documents. So families can and should put the IEP, the hospital records, the psych eval into their Beacon account, because then the state, once they sign the consent, all the state partners can see that. So they don't have to fax it to anyone to qualify for anything. If somebody says, do you have the psych eval? Do you have the IEP? They just say it's in my Beacon account, and then somebody can see it. Families told us they wanted that. That's why we built it. And then the last thing this does, which is not visible to anyone, it lets those 6 state agencies legally, securely communicate with each other all day long. So now, instead of there being a roadblock because someone at ISB or the school district doesn't know who to call from HFS to get a kid Medicaid enrolled, now they just, in Beacon, they literally pass it off to HFS and they say, next step, you enroll this kid in Medicaid. And it can happen so much faster because all of the state agency people are logged into the back end of Beacon. And that invisible piece was absolutely essential to getting people unstuck, because, and we can also see in real time where the holdups are. So I could log in, Megan can log in, and we can see like, oh, Dustin sent this to Kelly and it's been waiting for 2 days. Why is it waiting? And we know, and they know we can see it. Not that they wouldn't, not that they're not doing their best, but I'm just saying there's heightened visibility of all these processes. So we've been getting the word out about Beacon through any way we can, including conversations like this, but there are also recorded videos on our website. And I will send these slides to Jody so that she can give them to all of you. And they have links to our website, because also important for you, there are flyers for families translated into 7 languages, so that if you're working with a family and you want to say, go put your information in Beacon, Beacon is available in 7 languages, and you could give a family a flyer in their language that tells them what to do so that you can get them started down this path. Beacon, oh, this is our website. We have a website too. And our website has all the flyers and everything. And the link to our website with all the flyers is in this slide deck also. So Beacon is great, but it's not everything. It doesn't diagnose or assess. It doesn't prescribe services, and it can't make appointments at this time. Like I said, I'm dreaming of a system that's more like OpenTable, which hopefully we will have in 1.5 years, but I have to be patient. So this Beacon strategy will work better once we have all these other pieces. And you all, community networks, are one piece of what is going to make everything work better. But just this is my caveat slide, like that Beacon can't solve the whole problem, but it is a big piece of the solution. This is what Beacon looks like. And you get to it through that URL, beacon.illinois.gov, where you can create an account, or you would be creating an account for a family, like caregivers are supposed to create accounts because they are the ones who can give consent for information to be shared. So if you do this on behalf of a youth, you need to warn the family that someone's going to call them to get their consent. Nobody can see their information, even if you enter it, without the parent giving consent. Beacon is not a crisis line, meaning it's not monitored 24/7. It gets checked every morning and throughout the day, but like not if someone's in crisis, they should click crisis help and it will show them what the crisis resources are. This is how someone would create an account. And again, you could create an account for a family. You just have to tell them that someone's going to reach out to them. And if a family for some reason doesn't want to create an account, or if you don't want to create an account, and you just want to look around, you can do that. And if you say that you're looking for community-based services, it links you to these 5 tools, and more tools are being added. Like we had a meeting this morning with NAMI Chicago. They have a helpline and they want to be added to this list. Previously, we didn't add them because they weren't statewide, but they think we should add NAMI Illinois, which will get people to NAMI Chicago if they need it. If you do enter child information, though, you will get like a curated list of services that match the child's location and their needs. And Spider is the placeholder for the system of my dreams, which is being RFP'd by HFS, and hopefully the RFP will be released soon. But in the meantime, we're using Spider, which is the system that DCFS pays Northwestern to maintain. This is what I mentioned. If somebody wants a person to call them, then when it says, do you need more assistance? You click yes, and you get a little receipt that tells you that someone will call back in 24 hours. And this list here on the left is the type of list that you get, and anything in blue you can click on for more information. I mentioned that if you are in crisis, you click crisis help and you see the state's crisis resources on the right. And these are the languages that Beacon is available in. These are kind of the 7. There's some disagreement between a bunch of agencies, but this is basically the consensus on the languages that are the most prevalent in Illinois. So the flyer is available in these and the tool itself. We just don't have a multilingual team that speaks all of these languages, so we would have to find a translator if somebody wanted to talk to someone in their language, but they can use the tool. This is the team that is responding to Beacon requests. They are located in the Division of Mental Health in DHS. They work for Lisa Betts, and they are led by a portal manager and 5 clinical specialists and 3 resource coordinators. The resource coordinators are the people who call back the next day to say, what can I help you with? The clinical specialists are the people who help families get to a residential treatment bed, and they specialize in 5 areas that we observed were the most challenging and prevalent: developmental disabilities, internalizing problems, aggressive behavior and juvenile justice involvement, sexually aggressive behavior, and transition age youth. Those 5 areas, we have a person who is an expert in knowing what the treatment options are and what the best practices are. And then we have parent navigators who might be from CRSA, the Community Residential Services Authority, or they might be from NAMI Chicago, and they're willing to kind of do more hand-holding or at the elbow support for parents navigating specific situations. And none of these people were there before. Well, the navigators, some of them were there before. The clinical specialists, the resource coordinators are all new staff. So this is actually what it looks like when you're entering the information. This is a pretend case, but this is where you enter the basic info and then the living situation. I just wanted you to get the feel for what it's like if you were to enter it. It's mostly stuff you would know if you were helping a family. What type of issues the youth is having, and this list is key to the eligibility criteria of the programs. This is where we've been able to speed up something that took a long time because people were cross-checking eligibility criteria. This does it like that, just using an algorithm. It asks what services the family is currently involved in. Like, we would like to know if there's already an open case with one of these, because then we can get it to the right person. There is an integration between this system and the DCFS data warehouse. So if a youth is already like involved in foster care, the system will know. But anything else, it'll be quicker if you indicate it. And then you're asked what you're looking for this child and what type of funding they have. But this is for all kids. Like, They could have private insurance, they could have no insurance. If they have private insurance, they'll get a message saying you should first check with your provider panel because we don't want to send someone to a provider that isn't in their network when they could have gone to someone that would be covered by their insurance. And then they'll be given a list. And it looks like this. And then they'll be asked, would you like to talk to someone? And if they say yes, they will get this little receipt. So you've pretty much heard how parents are using, I'm going to skip some of these slides in favor of discussion if we have some, but these are the things that parents are using Beacon for, and these are the things that providers are using Beacon for, to open a case, to connect a family to more specialized services than what they provide, or to coordinate among providers. And I have a couple of vignettes of examples of cases that we've served through this process, which I can talk through briefly. These are actual cases where we've changed like a detail or two. In Amelia's case, she was 14, had ADHD, depression, and anxiety, and she was in the hospital for a suicide attempt, but she had also been aggressive toward her younger sibling, and she and her younger sibling were living with their grandparents, and the grandparents did not feel like they could bring Amelia home to their house. They were scared by the suicide attempt and by the aggression toward the sibling, and they were like, she can't come home to our house. So the hospital social worker entered Amelia's information into Beacon, and that let everybody start working on this case. This family had not been connected to any supportive services, but a Beacon clinical specialist worked to enroll Amelia in several programs through HFS, Pathways, FSP, and Interim Relief, and to get her an IM-CANS assessment, which is necessary to qualify for some of those. And the family support program, FSP, found a residential placement for her, and so she left the hospital and went to a residential treatment bed. And the second case I have is Eric. Eric was a juvenile justice involved youth who was 15, and he was involved with the CCBYS agency. I don't know if you're familiar with that program, but they are a diversion program to keep kids out of JJ and child welfare. And similarly, mom said, I can't have Eric back in my home. He needs to go to a residential placement. But no applications had been initiated on behalf of Eric. So the Beacon Resource Coordinator worked in partnership with the CCBYS program that Eric was already involved in. And they did a bunch of things. They enrolled Eric in Medicaid, signed him up for Pathways, and found a safe temporary placement for him with a relative. But because they provided this relative with so much supportive community care, the relative said they could keep Eric longer term. And so he didn't have to go to residential treatment, and he came out of the hospital into their home and has stayed in their home. So these are just two examples of like how this tool and this new process helps us all work together to get resolution. So I'm just going to say two more things, and then we'll have a little time for discussion. One is, if you are searching on behalf of a family, please provide them with the entire list of what you get out of these tools, because I know I get asked all the time for like therapy referrals, and if I get 10, I pass 2 along. And we don't want you to do that. We want you to give everything. One, because we want to empower families with the ability to see what's available to them and make decisions about it. And two, because the first 2 might not work out for them, and we want them to be able to independently access these things. So give them the whole list. Number 2, I already said this, please warn the person that somebody will call them. People are not accustomed to hearing from a human who's like, how can I help you? And we don't want them to either think, we don't want them to be surprised or think that their privacy has somehow been compromised, because, and that goes to number 3, please let them know that nothing can be viewable or seen or known without them giving consent. And if they can't give consent themselves electronically, the resource coordinator, when they call, will obtain consent from them and put it into the system. And that once consent is submitted, that unlocks the information so that the state agencies can start working on it. And then this is, as promised, all that information that will be in the slide deck, link to the blueprint, link to our website and to where those flyers are, and to Beacon, and my email address, so Marita or others can shoot me an email if they want to talk about this stuff. I think that is the end of what I wanted to say, right on time, Jody. So I'll pause screen sharing and see if people have thoughts.
That was wonderful, by the way. Thank you so much for sharing all that information.
Yeah, thanks for thinking to invite me back. I mean, like I said, I was worried it would be a repeat, but when I start talking, I'm like, oh yeah, I haven't told you any of this stuff. So,
It's great to hear. Do we have any questions or comments from anyone today?
Can you guys hear me okay? This is Lynn.
Yep, we can hear you just fine, Lynn.
Really helpful. Thank you. I can't, put my face on there and I can't really formulate a very smart question right now, but I appreciate the information. It's interesting to hear so much about DD in this conversation. I'm really grateful for that piece. Otherwise, that's all I've got right now. It is rush time and there's a whole bunch of fires to put out here. So I'm just really glad I could listen to y'all. Thank you.
oh, no worries at all. And yes, the kids with developmental disabilities are very much on my radar, particularly those kids that age into the adult system, because it's like a cliff. They have so much more support in the child system if they are lucky enough to get it, and then they age into adulthood. The providers who serve them get less money. They get less service, even though there's a bigger service array, they get less. And so I'm really trying to focus on safeguarding those kids, preparing them for community-based living with resources that we don't currently have in our state, but we're working to build.
I'm super aware of this, and I also want to share, there's a side effect too, that the fact that parents have to really work so hard to get what they can from schools. When
Yeah.
they the adult system, these are traumatized people.
Mhm.
They need to be treated a little bit differently than we afford ourselves the luxury of doing. Anyway.
Absolutely.
Looks like we have a question from Yosh about providing a link to the April 1st report on school screening.
Oh yeah, let me get that right now. Hold on. I might
Great.
even have it open on my browser. Let's see if I do. If I don't, I'll grab it. Here we go. Assessment of school readiness. I found it. Let me copy the link and put it in the chat.
Great, thank you.
There it is.
Perfect.
It's got a helpful diagram. I don't know what page it's on, but it shows like what the 3 phases would be and what percentages in each phase. And then it's got a good timeline too. There's a couple of graphics toward the end of it that you might find like a useful summary.
Great. We also have a question. Is there more information on the screener you are or will use?
Okay, so here's what I can say about that. In the first report, not the one I just posted, but the one before that, the landscape scan, we provided information about the 10 most frequently used screening tools. That's about as close as I can get to saying something because there will be an active procurement for the tool along with that system that HFS is building. And I can't commit to what the tool would be because it's something the state will be procuring. So I can't say it will be this one or that one. However, the list of tools in the initial landscape scan, which I guess I could find that and put the link in the chat also. The list of tools, it's probably going to be one of those tools. But I just can't like name a tool because because procurement laws are strict and I'm not supposed to do that. And we haven't settled on one officially. I'm just looking for the landscape scan. We haven't settled on one officially, but it will be procured in the context of the other tool. Here is the it has a weird name, but if you click on that, you'll get the landscape scan, and that has a list of the 10 most frequently used tools by Illinois schools.
Great. Are there any other questions? I don't see anything else in the chat.
Hello, Jody.
Hi, Herb, how are you?
I'm good. I'm running. I have a doctor's appointment, but I'm very glad that I zoomed in on this. Thank you. Thank you, Dana. That was great. I'm very impressed by this initiative. Its progress and potential for success. And highly informative. This was highly informative. And thank you. Thank you. Good to see everybody.
Thank you so much. Yeah,
Always.
it's exciting to be partnering with so many people. Like we keep track of how many people I talk to, and there are so many people who've put input into this. Like this recipe was not just my recipe. Like lots of people have ideas. In every room I go to, people come up with things. I'm like, oh, we should try that, or we should, so it really does feel like a collaboration. I'm glad it
Absolutely.
resonates with you all.
Very comprehensive. And hello, Lynn, and hello to all the other participants. Great presentation again. Thank
Thanks.
you.
Thanks, Herb. Well, we will share the link to today's presentation and with the slide deck, and I'll make sure to add the additional links here in the chat. And then if there's any other questions, follow-up questions that you think of for Dr. Weiner, feel free to send them to me and I will pass them along. Or you can reach out. I think your email was on there perhaps.
Yes.
Directly. So thank you so much, Dr. Weiner. I was like echoing what everyone else said. It was a wonderful presentation. We thank you and appreciate your time today.
Oh, my pleasure. Good to see you all, and I will send you that, Jody.
Okay, sounds great. Thank you.
Bye-bye.
Bye, everyone. Thanks for joining us today.